The peak of the COVID-19 pandemic in New York was absolutely overwhelming. There were hundreds of patients presenting to the emergency department, many of whom were very sick and required admission, intubation, and many of which died. In our clinical observations, we noted that there was a high rate of decompensation early in patients' hospital admissions, and that there was a particular phenotype of patient that was particularly associated with decompensation. This included older patients, those with comorbid illness, especially hypertension, diabetes, and cardiovascular disease, those with certain laboratory abnormalities, including elevated troponins, and those with abnormal EKGs. My name is Tim Poderuka. I'm a cardiology fellow at Columbia University. I would like to tell you about our paper, Prognostic Value of Electrocardiography at Presentation to the Emergency Department in Patients with COVID-19, in an upcoming edition of Mayo Clinic Proceedings. This was a retrospective study that was conducted at the peak of the COVID-19 pandemic in New York. In this study, we sought to take our experience and develop a score or a marker of what patients were most likely to decompensate within the first couple days of a hospital admission. This study analyzed 1,258 patients that presented with COVID-19 to Columbia University in the months of March and April. This was primarily an inpatient study. In this study, we evaluated patients' demographics, comorbidities, laboratory changes, and electrocardiograms in an effort to identify variables that were associated with early decompensation. Of note, all electrocardiograms had to be performed within 6 hours of patient presentation or of diagnosis of COVID-19, and every EKG was systematically read by a board-certified electrophysiologist. So we started with a little over 5,000 patients that were tested across 3 hospitals, 2,400 of whom tested positive for SARS-CoV-2. We evaluated a total of 1,258 of those patients who underwent systematic evaluation. We noted that this cohort was very sick. 18% of patients were dead at 14 days, and 14% of the other patients had required mechanical ventilation, many of whom remained intubated even 14 days after diagnosis of COVID-19. About 2/3 had a favorable outcome, which we defined as being alive and not requiring mechanical ventilation. These are the patient characteristics of patients that were evaluated in our study. What we noted is that patients were older with a mean age of 61 years, and there was a preponderance of male gender. This cohort was highly comorbid, with some type of comorbidity seen in 83% of patients, the most common of which was hypertension, diabetes, lung disease, and various cardiovascular comorbidities. The most common presenting symptom was fever in 39% of patients and cough in 32%. Abnormal vital signs were very common, with a low oxygen saturation seen in 57% of patients and an elevated respiratory rate in 28% of patients. In the analysis of electrocardiograms, we found that common findings included prolonged QT, ST changes, and atrial fibrillation. Of note, these findings were associated with worse outcomes. During the next phase of the study, we did univariate analysis on multiple factors to try to identify predictors of early decompensation. We found that patients who are older, male gender, had comorbid high blood pressure, diabetes, and chronic kidney disease, and those who had abnormal vital signs, especially respiratory vital signs on presentation, were more likely to die or require intubation within the first 48 hours. In terms of laboratory findings, we noted that those with high creatinine and high inflammatory markers with an elevated CRP were also more likely to have adverse outcomes at 48 hours. Common EKG findings that were associated with worse outcomes included atrial fibrillation, ST and T wave changes, and RV strain as detected by an S1Q3T3 pattern. In order to develop an effective triage tool, which could identify patients at highest risk for early decompensation, we sought to evaluate whether vital signs on presentation and EKG changes could accurately predict a very high-risk group of patients that may warrant more aggressive monitoring or more aggressive interventions. We assessed the ability to prognosticate 48-hour outcomes based off just two factors. The first is respiratory vital signs, and the second is the EKG. For respiratory vital signs, we define normal as having a respiratory rate of less than 20 or an oxygen saturation of greater than 95% without having to receive non-rebreather therapy or full face mask. For the EKG, we took the presence of any one of three high-risk features. These features were right ventricular hypertrophy by S1Q3T3, the presence of atrial fibrillation or flutter, or any ST elevation or depression. We found that the combination of an abnormal respiratory vital sign and an abnormal EKG was highly predictive of adverse outcomes, with 31.5% of those patients dying or requiring intubation within the first 48 hours. For patients that had a normal EKG without any of those three factors and normal respiratory vital signs, their risk was much lower at 4.6%. Other significant findings from our paper is that we found that patients were most likely to develop respiratory decompensation on the day of admission, with the most common day of intubation being on the day of admission. Previous work in COVID-19 has found that respiratory abnormalities like cough and shortness of breath develop fairly late in the course, 6 to 7 days after the onset of symptoms. But once respiratory signs do develop, the risk of sudden decompensation is very high. Our work confirms this in a cohort in the United States. Other findings include that patients, once intubated, tend to stay sick for a long time. This was something that we noticed clinically, that very few patients seem to be able to be extubated within the first 1 to 2 weeks. We find that this is the same in our entire cohort, with up to 3/4 of those who are intubated still requiring mechanical ventilation at 14 days. For a patient that's concerned that they had COVID-19, it's important to recognize that problems with breathing require urgent evaluation. This is not the type of thing that is best to watch and wait. Once things like shortness of breath, high fevers, and cough develop, it's critical to speak with your physician or go to the emergency department to be evaluated. Our findings are important for other providers taking care of patients with COVID-19. During the peak of the pandemic, we found ourselves nearly overwhelmed with the influx of very sick patients. By adding a simple triage tool that would take a group of patients and identify that they were at very high risk of decompensation, that can help to identify those patients that may warrant the most aggressive treatment and monitoring. In summary, we found that the addition of an EKG to respiratory vital signs accurately identifies a high-risk group of patients that may warrant more aggressive treatment and monitoring. Adding in evaluation of an EKG can absolutely help physicians triage their patients appropriately with suspected significant illness due to COVID-19.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.